Hi, folks. Welcome back. This is going to be the second of the two-part introduction to receptor pharmacology. We're going to break this up into three parts. The first part, we're going to talk about a little bit about neuroanatomy and monoamines. And then the second part, we're going to talk about non-monoamine neurotransmitters. And then the third part, we're going to do an application for how we treat ADHD. So we'll break this up into those three parts. Really want to focus on the remaining neurotransmitters beyond GABA and glutamate, which we talked about in our last session, and then begin to give you kind of a hint of what medications work on these different neurotransmitters. We'll go into greater depth when we cover the individual drug classes in future weeks. And then we'll finally apply it to the treatment of ADHD. So for this first part, we're going to talk about monoamines, and by that I mean histamine, norepinephrine, dopamine, and serotonin. We'll leave the folks on the left there for the second half. So one of the things that I just want to cover briefly, we're not going to get too deep into it, is the use of neuroanatomical nomenclature. So the brain is a tricky thing to kind of map out because if you've seen one, you know it's kind of a big blob, right? Lots of wrinkles, but the areas that are functionally related are not always immediately obvious from tissue in the same way that, say, blood vessels are as they are related to the heart. And so there's a number of different conventions for labeling different areas of the brain. So one thing you see up here is something known as Brodmann's areas, which are numbered. More often, what we see are these kind of anatomical descriptions. So, just as we would use as a map, these are relative, so for example, when I say relative, Colorado, of course, is east of us, but it is west of New York. So sometimes when we talk about something being anterior or posterior, it's relative to another location. So just going back to our early anatomy days, you remember our terms such as anterior, also known as ventral, posterior, also known as dorsal. And the way I remember that is a dorsal fin of a dolphin or a whale or something is coming out of its back. We also use the term superior, sometimes to mean dorsal. So this idea of, you think of like a dorsal fin, and ventral sometimes also refers to inferior or lower. And then to make things more confusing, there's this idea of rostral and caudal. Rostral is towards the front, caudal is towards the back of the brain. And we also have terms that sometimes are descriptive, like some substantia nigra, which means literally black stuff in Latin, because it is a pigmented area of brain tissue that's related to movement disorders and smoothing of movement of the brain. And so taking a look at this sagittal slice here of a brain, so cross section right through the middle is what we're looking at, because you can kind of see the profile of the nose here. Um, that area that you see lit up there is the cingulate cortex. And so you might see something like this, which of course is sort of unsatisfying because it's an attempt to draw a three-dimensional object on a two-dimensional plane. But this, again, is sort of a cross-section of the brain. And you'll see these abbreviations, which are commonly areas that are commonly talked about, say, in mood disorders. So ACC would be the anterior, meaning towards the front, cingulate cortex. So it's anterior to the cingulate cortex. It's in front of or towards the front of the brain, towards the eyes, if you will, of the cingulate cortex. The dorsal medial prefrontal cortex. So dorsal meaning behind the prefrontal cortex. And then the ventromedial prefrontal cortex. So again, saying ventral towards the front, medial towards the midline, prefrontal cortex in the front area of the brain. Not the most intuitive terminology, but after a while you start to get used to hearing these terms. And then, of course, the simplest version that we have, that we learned in grade school, is the four lobes: the frontal, temporal, parietal, and occipital lobes. And this becomes more relevant. I'm not going to get into this in too much depth here, but when we start talking about functional networks, which is really something that you're going to hear more about, I think, in the years ahead, certainly in the lifetime of your careers. Now, functional networks refer to areas of the brain that work together to do a task. and they may not be anatomically next to each other. So one area might be towards the rear, another area might be towards the front. But when we stick people in an fMRI scanner and we measure their blood flow as the proxy for neural activity, because if you recall that the brain uses a lot of glucose, it uses a lot of oxygen. And so wisely, it sort of shunts the blood to the areas of the brain that are doing a lot of work in a given moment. And we can monitor that with an fMRI scan. And this helps us to understand areas of the brain that work together. These are known as networks or functional connectivity. Probably the most well known is known as the default mode network. This is kind of like almost like a mohawk-like strip through the middle of the brain. It got that name because when we got fMRI scanners about 25, 30 years ago, stick people in the scanner, ask them not to think about anything, and lo and behold, this area of the middle of the brain lights up again and again. You ask the person in the scanner, hey, whatever you're thinking about, please stop. They say, I'm not thinking about anything. This area of the brain lights up. Turns out that is the area of the brain that kind of lights up when we are introspective. It also is an area of the brain that lights up when we're really depressed, often, especially with this sort of ruminative kind of depression that many people have, where they're kind of thinking about what a terrible person they are, but not able to focus on outside things. And the reason for that may be that there's another network known as the task positive network. And you can think of these as sort of two sides of a seesaw. So you can't have both turned on at the same time. You can't be inwardly focused and externally focused as you are when you're using your task positive network. So your task positive network is active when you are, say, scrolling through your email in the morning, because embedded in your task positive network are two subnetworks, one of which is called the salience network, which, as you might imagine from the name, it's sort of picking up what's important. And another is called the executive network. So it is deciding what to do with that information. So as you scroll through your email, you see something, you see junk, 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 delete, delete, delete. And then you see something from your boss and you think, oh, I've got to respond thoughtfully to this. You're going to engage your executive network. By the way, classical psychedelics such as psilocybin seem to disrupt these networks for at least a period of time, and possibly when they wear off, things are reset in a different way. But that's more content for a later date. But just kind of want to give you an idea of what we're talking about when we discuss functional networks. So neurotransmitters, what are they and where do they come from? So remember last week we talked about how the brain is made up largely of proteins. Neurotransmitters are a type of protein, and all proteins are made from amino acids. So in the case of this example, the neurotransmitter dopamine is made from L-tyrosine, the amino acid L-tyrosine. Before it becomes dopamine, it becomes L-dopa, if you're following this from left to right. And interestingly, dopamine is the parent to norepinephrine. Norepinephrine is converted to epinephrine. So all this comes from L-tyrosine. Now, GABA and glutamate, as we talked about last week, are widely distributed through the brain. They're kind of like those Amazon distribution centers, which allow you to get your goods, later today or tomorrow, because somewhere nearby your house is probably an Amazon distribution center, which means things can get to you fairly quickly. And GABA and glutamate, similarly, are widely distributed throughout the brain. Other neurotransmitters, however, are made in specific localized areas and then radiate out through the cortex. So they're more like Temu, so when you order something from Temu, it's coming all the way from China. It's got a long way to go. It might be a few weeks before you get it. And that's because it's coming from a long distance. So similarly, things such as dopamine, which is synthesized in the substantia nigra and the ventral tegmental area, so deep in the midbrain, norepinephrine, which is coming from the locus ceruleus, and acetylcholine, which is coming from these midbrain pontine areas. So these are all made in a local area and then distributed out throughout the brain. So let's take a look at the monoamines first. So the first monoamine we're going to look at is histamine, and we kind of get that tip off that it's an amine because it's got the tail end is amine, so histamine. So histamine is many people, when they think of histamine, they think of allergies. They don't really, or inflammation. They don't really think about psychiatry. But turns out that histamine is one of the important things that modulates whether we're awake or not, and how cognitively intact we are, how cognitively alert we are. And you know this if you have taken a centrally acting, and by that I mean something that penetrates the blood-brain barrier and hits central histamine receptors in the brain, antihistamine. So a histamine antagonist or inverse agonist, something that blocks the effects of histamine in the brain, generally makes us tired and sleepy. So the classic of that would be diphenhydramine or Benadryl, which we sometimes use in psychiatry as a means of inducing sleep. A lot of your patients will show up into your office having tried something like Tylenol PM for insomnia. And it's not the most precise drug, but it often will get people drowsy. And so doxalamine would be another one. And hydroxyzine is another antihistamine that we sometimes use in psychiatry for its kind of calming effects. Most of histamine's activity that we normally think about is in the periphery. So these things that are outside of the blood-brain barrier. A lot of our inflammatory responses, obviously allergic responses are largely modulated through histamine because there are histamine receptors on mast cells. And so when mast cells degranulate, they release histamine, and that increases permeability of blood vessels, which leads to swelling and inflammation. So drugs that relate to histamine, I've talked about the inverse agonists, so the histamine 1 receptors that do penetrate the blood-brain barrier. Obviously, there's a whole new class, relatively new in the last 30 years, of peripheral histamine receptors, inverse agonists rather, that do not penetrate the blood-brain barrier. So these would be your Claritin type drugs. That's why they don't make you drowsy. They don't get into the brain and attach themselves to those central histamine receptors. There are also some non-amphetamine stimulants that have complex mechanisms of action, but one of which is that they are histamine agonists in the central receptors. So this would be things such as modafinil and armodafinil. And a lot of the side effects from medications that are useful to us, some of the more sedating antipsychotic dopamine blocking drugs, such as chlorpromazine, often have significant antihistamine effects. In fact, chlorpromazine was originally a surgical anesthetic that was found to have this greatly sedating effects, which is why it would be valuable in surgery. But somebody got the idea of what if we gave this to people with psychosis and agitation? And it was those sedating effects that were first found to be useful in psychiatric hospitals. A lot of times, the side effects that we're dealing with from other medications, such as olanzapine or quetiapine, that sort of weight gain and sedation, is partially mediated through histamine. Also, it's worth noting that if you've ever worked in a med-surg setting, you've probably had older people admitted for altered mental status that maybe had been taking large doses of antihistamines in addition to possibly other anticholinergic drugs, such as, say, ditropan. And as it turns out, if you block enough histamine receptors and if you and have to deal with the anticholinergic side effects of that. Many people are familiar with kind of dry mouth that you get from those centrally acting antihistamine drugs like Benadryl. Enough of that, especially in an older person who has less sort of capacity to deal with that acetylcholine blockade, and we'll talk more about acetylcholine in a few minutes, can get delirious and get very confused and have hallucinations and have confusion. And apparently this is sometimes used in young people who will take high doses of diphenhydramine or Benadryl. And there's this online trope that apparently one of the common sort of visual distortions is known as the Hat Man, and so just worth knowing about, especially if you're working with younger patients. Let's talk about another amine, another monoamine, dopamine. So certainly getting a lot of press these days. It seems like everyone's talking about dopamine. So dopamine is one of these ones that originates from a central area of the brain, the ventral tegmental area, and also the substantia nigra. And this is coming from tyrosine, and it's broken down by monoamine oxidase. So there's that word again, amine. Monoamine oxidase is the oxidizing enzyme which breaks down all of these monoamines. We have 5 different receptor sites for dopamine. Mostly we're going to be talking about D2 because that is the target for most of the dopamine blocking antipsychotic medications. Dopamine has a lot of different roles in the body. So obviously we're familiar with its role in mediating psychosis, but it also has an important effect on mood and also in addiction. So substance use disorders have a significant component that is mediated by dopamine. And it's one of the ways that we register reward and also craving. Interestingly, dopamine is involved in the regulation of prolactin, the hormone prolactin, which is a significant determinant of whether or not somebody lactates. And we think about dopamine also in movement disorders, particularly Parkinson's disease. So some of the side effects that we get from dopamine blocking drugs look very much like Parkinson's disease because of the way that those drugs will block dopamine receptors in the areas of the brain that are responsible for movement. Talk more about that in a moment. So as you can see, this sort of pathway, so phenylalanine is the precursor to L-tyrosine. L-tyrosine becomes L-DOPA. You may be familiar with L-DOPA in the treatment of Parkinson's disease. That becomes dopamine once it's converted from L-DOPA. Dopamine is converted into norepinephrine, and then norepinephrine is converted into epinephrine. So you see this relationship between two monoamine neurotransmitters, both dopamine and norepinephrine. There are four pathways for dopamine, and this is important to understand when we start to talk about dopamine blocking drugs for the treatment of psychosis. So this has been critiqued as being oversimplified, which it probably is. And I think in the time of your careers, you will probably see some continued refinement of this idea. But this is important to understand for beginning to understand how dopamine blocking drugs work. That the goal that we have in treating psychosis is to block dopamine in some areas, but not others. So let's elaborate on that. So these four pathways consist of the mesolimbic pathway. So this is this area, this small area in blue at the base of the brain. And this is important areas. This involves things like the ventral tegmental area and the nucleus accumbens. And this is where we register reward. It's also thought that overactivity in this region of this dopaminergic region is responsible for psychotic disorders. So when we overstimulate this area, say with an amphetamine, we can begin to see psychosis symptoms emerging. It's also thought if this area is sort of underactive, then people may have difficulty experiencing reward. The mesocortical area is more involved in the prefrontal cortex. So this is what we need dopaminergic activity for cognition here. And so one of the things that we're often doing with stimulant drugs, for example, which we'll talk about in a few moments when we discuss ADHD, is increasing dopamine activity in the frontal lobes of the brain. So this helps to improve cognition and focus. Now, there are a couple of functions of dopamine that don't have much to do with psychiatric presentation, but often can result in some side effects that we see. One of which is dopamine is critical in the nigrostriatal area. So when dopaminergic neurons are dysfunctional in this area, we see the symptoms that are familiar in Parkinson's disease. So things such as bradykinesia, difficulty with initiating movement, tremor, etc. Often when we block dopamine in this pathway with our dopamine blocking drugs, also known as antipsychotics, we see some of these similar symptoms. We see slowness of movement, we see tremors, etc. And then the tuberoinfundibular tract is what regulates lactation. So when we block dopamine here, we release prolactin. And it's that release of prolactin that can lead to gynecomastia, which is the development of breast tissue. We can also see galactorrhea, and that's production of breast milk when somebody should not be producing breast milk. And that can happen in all gender patients. So dopamine, we're kind of looking for this sort of sweet spot with dopaminergic tone. If we have too little dopamine activity, we have the sort of symptoms that we see with like ADHD. So we see difficulty with impulse control, difficulty kind of filtering out extraneous stimuli. So if you're listening to this lecture and you're getting notifications on your computer, I'd suggest that you turn those off, by the way, and you're getting distracted by those, that may be that function is really one of the things that's mediating that is dopamine. And then obviously, if we have too little dopaminergic activity in that nigrostriatal tract, we can see those Parkinsonian type symptoms. If we have too much dopaminergic activity, that's usually, well, obviously, a transient increase in dopamine is associated with pleasure of many different forms, as simple as a glass of water or orgasm, or satiety from eating, but it can also be hijacked by drugs such as cocaine or amphetamines. And if we overstimulate that pathway, we can start to see symptoms of psychosis and things like paranoia and inability to sleep. So we want this sort of sweet spot with dopaminergic activity. And as I mentioned, many of our ADHD meds will also influence, are going to influence dopamine, such as the amphetamines, both by causing it to be released and preventing it from being taken back up into the presynaptic terminal. Some of our antidepressants, such as bupropion, do work somewhat on dopaminergic transporter or dopamine reuptake. The two words for the same thing. Transporter is the thing that takes the neurotransmitter back up into the presynaptic terminal. We have our antipsychotic medications, dopamine blocking drugs of the first and second generation, which we'll take a deeper dive at a later date. And then drugs that are used to treat Parkinsonism. So these can be direct dopamine receptor agonists. Sorry, I might have had a little technical glitch there. Next neurotransmitter in the monoamine area that we're going to talk about is norepinephrine. So norepinephrine is the primary neurotransmitter of the sympathetic nervous system. So when we think about sympathetic nervous system, we think of fight or flight. We should also be thinking about attention and mood. And this is coming from the locus ceruleus. So in that central brainstem, top of the brainstem, as you recall, it is synthesized from dopamine. It is also broken down by MAO. And you may be thinking, I know that term from somewhere. Maybe you're thinking of MAO inhibitors, which were the first antidepressants back in the 1950s, prevented the breakdown of monoamines. So you can start to see how that would increase the availability of these neurotransmitters at the synapse. And we have we have two families, alpha and beta, which have two subfamilies each. So there's alpha 1 and alpha 2 and beta 1 and beta 2 norepinephrine receptors. And the terminology here can get a little bit confusing because people will often talk about alpha 1 receptor agonists or something like that. And they often will omit the word norepinephrine. So you got to listen for that. So when we're talking about, say, alpha 2 receptor antagonists, there is that unspoken norepinephrine alpha 1, norepinephrine beta 1 receptor antagonist. And, we're all familiar with the term, say, beta blocker, but that's referring to beta 1 norepinephrine receptors that we are antagonizing with a drug like propranolol. A little finer point on how norepinephrine fires at the locus ceruleus. So we've got two different patterns that are happening. So one is that you got to remember that these receptors are not just off, until a neurotransmitter or some other agonist comes and activates it. That receptor always has a certain degree of what is called tonic firing. So you can just think of this as like boop, 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 boop. Now we think that one of the things that might be going on in depression is that tonic rate, that background rate, may be slower. This may be associated with diminished sort of cognitive sharpness, and maybe symptoms that we see with ADHD. Now, that neuron will begin to fire much more quickly as it's activated in response to a strong stimulus. So if I'm walking across the street and I see out of the corner of my eye that a car is not going to stop, that norepinephrine receptor, that norepinephrine synapse is going to start firing really rapidly, going from that boop, boop, boop. It's going to go boop, 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 right? And that rapid firing is going to make me orient towards the potential danger. It's going to get me ready to move. So that's my fight or flight. Okay. And we can also think of that maybe being part of what's going on when people have panic attacks. So panic attacks might be thought of as like the smoke detector in your house when it goes off when there's really no danger. You know, when you're cooking dinner and your smoke detector goes off, that is your alarm system that has become sort of hypersensitive. And that fight or flight response is what we see in people when they have panic attacks. They get tachycardic, they get short of breath, they get sweaty. Those are all things that we would need in order to deal with a physical threat. That's what happens when our sympathetic nervous system goes off with this kind of phasic firing. So let's take a look at these different receptors. So we've got these two families, alpha and beta. We've got the beta, things like propranolol, beta 1 receptor antagonist. We've got alpha, which is broken up into two subcategories, alpha 1A and 1B. So a 1A antagonist would be prazosin or doxazosin, something that we use in the treatment of nightmares in PTSD. And then we have alpha 2A agonists, such as clonidine or guanfacine. These are often used because they actually increase the activity of dopamine in the prefrontal cortex and are used to treat ADHD. But peripherally, they function as antagonists, and so this is why we're also using them in blood pressure management. So as I mentioned before, bupropion is primarily a norepinephrine reuptake inhibitor, which is going to help to address mood symptoms. Alpha antagonists such as prazosin, alpha agonists are going to activate. Sorry, I think I spoke. I misspoke. I said dopamine. I meant norepinephrine is what we're increasing with the drugs that are used for ADHD, such as guanfacine or clonidine. Sometimes see those used in children, especially in children that we don't want to use a stimulant on for whatever reason. We sometimes use beta antagonists, so propranolol, for example, to block sort of the peripheral effects of anxiety. So they really don't do much for the sort of internal cognitive worry part, but they are helpful for, say, shaking hands and things like that. I've had patients who are musicians that will use propranolol before a big performance so that their hands don't shake. And then we'll talk more about the stimulants, the amphetamines and the methylphenidates, and how they affect dopamine and norepinephrine in a few moments. And then some of the drugs that are marketed for as non-stimulant alternatives for ADHD. So things such as atomoxetine and a newer drug called viloxazine or Quilibri, I believe is the brand name for that. They in part work to prevent the reuptake of norepinephrine. So much in the same way that bupropion does. In fact, bupropion can be used for ADHD to improve attention. Our next neurotransmitter, monoamine neurotransmitter, is going to be serotonin. We talk a lot about serotonin in psychiatry. It actually occupies a relatively small amount of brain activity, but it gets a lot of attention because it's a useful neurotransmitter to manipulate for certain conditions such as mood and anxiety. This monoamine neurotransmitter, serotonin, which is often referred to as 5-HT, which is short for 5-hydroxytryptophan, which is the amino acid from which it is synthesized, comes from the dorsal raphe nucleus. So that's again, also in the midbrain, also broken down by MAO. So you're starting to see a pattern there. And there's a lot of receptors. I have always been taught that there were 14 receptors for serotonin. I recently heard somebody say that there are 21. So this is probably an evolving story. Serotonin has a lot of different roles in the body. So we're most familiar with its function in mediating mood and anxiety. Serotonin and dopamine have a relationship in which serotonin 2A receptors, when blocked, cause dopamine to be released in the mesocortical area of the brain, We'll get closer into that when we talk about dopamine blocking drugs. But there are also these peripheral functions of serotonin. You've probably heard that much of the serotonin activity in our bodies actually is in our guts, not our central nervous system. So we definitely see some regulation of, say, gut transit time with serotonin, which may be why some people get diarrhea when they have more available serotonin from, say, an SSRI. But there are also serotonin receptors on platelets, which have some effect on bleeding and bruising, which is why sometimes people on SSRIs will bruise more easily. Yawning is somewhat mediated by serotonin, as can be blood pressure. And of course, sexual function is another thing that serotonin is closely involved with, which is why SSRIs can sometimes impair things such as ability to orgasm. Serotonin, as I mentioned, comes from tryptophan. It is converted into 5-hydroxytryptophan, and then that becomes serotonin. You'll notice here that serotonin is the precursor to melatonin, another monoamine neurotransmitter. And just as an aside, psilocybin is a prodrug for the drug psilocin and is converted to psilocin by breaking off a phosphorus group on the psilocybin molecule. So psilocybin is essentially a prodrug for psilocin. Okay, so moving on here to the different ways that drugs will affect serotonin. We have a bunch of different options for manipulating how serotonin acts in the central nervous system. So let's take a look at these in turn. So we have things that break down serotonin, MAO, and we can inhibit those. We can also cause serotonin to be released, and we can so serotonin releasers, probably the best example of that would be MDMA, which is it is in the amphetamine group, but unlike other amphetamines, which largely release dopamine and norepinephrine, MDMA is largely a serotonin releaser with a little bit of dopamine and norepinephrine release. But that is a way that we can manipulate serotonin. And then probably what's most well known are the drugs that prevent its transporter from working as well. So the reuptake pump, as it's sometimes called. So this would be our SSRIs, our SNRIs, and our tricyclic antidepressant medications, which when we get closer into those later on, you'll see are also SSRIs and SNRIs, and we'll explain that more in detail later. So taking a look at these different receptors, we have the 7 major groups of serotonin receptors, and then we have subfamilies. So within serotonin 1A, so or 5-HT1, as it's sometimes referred to, we have 1A, 1B, and 1C. Within the serotonin 2 family, we have 2A, B, and C. And we have different agonists for these receptors. So serotonin 1A receptors would be things such as buspirone or buspar. CBD, cannabidiol, is also a serotonin 1A agonist. It activates that receptor, as does vortioxetine, a newer antidepressant, sometimes called Trintellix. The drugs that we use for the treatment of migraine headaches, the triptans, are usually serotonin 1B and 1D agonists. And then some drugs that work on the serotonin 2A receptor, for example, would be some of your classic psychedelics, such as psilocybin and LSD. A drug that worked on serotonin 2B was fenfluramine. This is a diet drug that was actually taken off the market some years ago because it was found that chronic activation of the serotonin 2B receptor was associated with valvular heart disease. So the thickening and hardening of the valves in the heart, which obviously is not a good thing. And cisapride is I believe, a drug used for acid reflux. And then sometimes we block serotonin receptors. So these are some serotonin receptor antagonists. Apologies about the animation on the slide here. So the serotonin 2A antagonists are probably most familiar to people watching this. This would be your second generation, sometimes called atypical antipsychotics. Trazodone and mirtazapine are also serotonin 2A antagonists. And ondansetron or Zofran is a serotonin 3 antagonist and is obviously a very useful drug for the prevention of nausea. So those serotonin 3 receptors are largely concentrated on the chemoreceptor trigger zone of the brainstem. And so by blocking them, we get the antiemetic effects of ondansetron. So familiar drugs to many of us, serotonin antidepressants, the SSRIs, buspirone, which is this serotonin 1A partial agonist, the second generation or atypical antipsychotic, dopamine blocking drugs also block serotonin 2A receptors. The selectivity of dopamine blockade to the D2 receptor, dopamine 2 receptor, in addition to blocking serotonin 2A receptors, is what makes a second generation antipsychotic unique from its first generation drugs, which generally did not have any blockade on serotonin 2A. And then, as I mentioned, there are drugs that activate serotonin receptors in the psychedelic class, such as LSD and psilocybin. 5-MeO DMT is probably a serotonin 1A agonist, and we can have direct release of serotonin, as we see with MDMA. An example of a work team here, you remember we talked about that organizational chart, would be dopamine and serotonin as they relate to each other with the use of second generation dopamine blocking drugs or antipsychotics. Because here, what we want to do is we want to decrease dopaminergic activity in the mesolimbic area, but we want to really increase it or at least preserve it in the mesocortical area. And one of the ways that we can do that is by blocking serotonin 2A receptors. Because what that does is it by blocking serotonin 2A, we get this disinhibition of serotonin release in the mesocortical tract. So what this essentially allows us to do is to get dopamine where we want it and prevent it from being overactive in areas that we don't in the mesolimbic tract. And then finally, our last amine, monoamine, would be melatonin. So as you recall, melatonin is synthesized from serotonin. And melatonin, interestingly, is made in the pineal gland in response to darkness. So we have receptors in our eyes, in the retina, that synapses through the suprachiasmatic nucleus and connects to the pineal gland. And so when things become dark, this signals the pineal gland to begin to release melatonin. When we start getting melatonin coming from the pineal gland, we get tired, we get sleepy. And this is partially what entrains us for sleep. So this is what entrains the circadian rhythm. And you know this can be out of whack. If you've traveled east-west, you know that the change in body time takes a bit of time to occur. And one of the ways that we can help that along sometimes is with exogenous, orally ingested melatonin, which is, of course, a commonly used sleep agent. It doesn't really work that well for keeping people asleep, but certainly helps people to get to sleep. And we have two receptor types for that. So we have MT1 and MT2, which are melatonin receptors. And there are some drugs that work on that. Obviously, over-the-counter melatonin is going to act on those. And we have prescription agonists such as Ramelteon. There's a drug that is an antidepressant available in Europe that one of its mechanisms of action is as an MT1, an M1, and M2 receptor agonist. So by hitting those melatonin receptors, it helps people fall asleep. So that's all on the on monoamines. And for the next part of the talk, we'll take a little pause here, and then we'll talk about the non-monoamine neurotransmitters. So thanks for your attention.